Dr. Smith, thank you very much for joining us. We're going to talk about your area of specialty, which is radiation oncology. So let's get a definition out of the way. Okay. What is radiation oncology?
Well, first, let me thank you for inviting me to come here.
Well, we're glad to have you.
Radiation oncology is one of the three main methods of treating cancer patients. All right. You have surgical oncology, medical oncology, and radiation oncology. And much like a stool, the three work together to support the structure.
All right.
Surgical oncology is a local therapy. Surgeon goes in and tries to remove the tumor or removes as much of it as he can. Radiation oncology, much like surgical oncology, is a local treatment. We aim our beams of radiation at the tumor or the nearby sites to try to sterilize the area where the tumor might lie. Medical oncology, on the other hand, is usually a systemic treatment where you try to treat not only the local disease but any metastatic disease or disease that might be located elsewhere in the body. So radiation oncology is one of the three parts of treating a patient with cancer, and it is a local therapy that uses high-intensity beamlets of radiation that can be of many different types to go in and kill the cancer cells.
Well, that segues into our next question. How does radiation kill cancer cells?
Well, it really depends upon the type of radiation being used. You have really two main types of radiation. You have wavelength, which is much like a light beam, and then you have particulate radiation. What we have here is a photon-based treatment system. And what it does is sends out a wavelength of radiation, like a light beam, that penetrates into the skin, and when it does, it starts to slow down, and in doing so, it deposits energy. It can deposit energy in two relatively different areas. It can deposit energy directly into the DNA, in which case it will disrupt the DNA molecule and kill the cell, or at least stop the cell from being able to replicate. Mm-hmm. It can also cause water molecules, and water molecules make up about 90% of a cell, to become disassociated. It will make a hydronium ion and a hydroxyl ion, and those two are free radicals, and what they do is they then can interact with the DNA, causing cellular damage. So basically what we're doing is we're causing cellular damage at the DNA level that will either kill the cell outright or will cause the cell not to be able to successfully reproduce. With the type of radiation that we're using here, about a third of the damage is caused directly by the wavelength of light affecting the DNA, and 2/3 are caused by the creation of the hydroxyl ions, which then damage the DNA. About maybe 10% of the cells will die directly from the effects of the radiation. The other 90% will die when they attempt to reproduce.
Okay. Next question. How effective is radiation in treating cancer?
If we can get enough radiation dose in to a tumor, we can eradicate it. The problem is different types of cancers require different amounts of radiation in order to respond. Some cells are more radio-resistant than others. Some cells are more radiosensitive. When I was a resident, I had a young patient who came in who had a lymphoma that was blocking her airway. We gave her one dose of radiation. The next morning, she came down breathing on her own. We were able to shrink the tumor that much in a 24-hour period. On the other hand, I treat prostate cancer, and I treat the patient, go through the entire course of therapy. And it's a year to a year and a half later before we really know how successful we were in treating the patient. We also have some tumors which we can't treat because of the side effects we cause to the local areas, such as kidney cancer, renal cell carcinoma. We really are not good at treating the primary lesion because we would destroy the kidney if we were to attempt to treat it. So radiation is a good tool if used appropriately, and we have to be careful with what we do.
Well, then, based on what you just said, let me ask you this. What types of cancers are typically treated with radiation?
Typically, in an average practice, about a third of the patients are breast cancer patients, about a third are prostate cancer patients, and about a third is everything else, with the vast majority of it being lung cancer, and then head and neck cancers being the fourth thing down. But we can treat anything where we can aim our beam of radiation, so anything that's not a freely mobile structure. In the gastrointestinal tract, we can treat head and neck cancers, we can treat esophageal cancers, we can treat stomach cancers. We're not very good at treating small bowel cancers because the bowel is moving, and we really don't know where it's located at any given time. On the other hand, we can treat rectal and anal cancers because they're frozen in space.
How then is the decision made to use radiation, chemotherapy, or both in treating cancer?
Some of it is historic. We know how certain types of cancers respond to certain types of therapies. So as I said, we really know we don't want to treat renal cell carcinomas because we know we would destroy the kidney if we were to try to treat those. Prostate cancer is equally successfully treated with either surgery or with radiation, and it's really the patient's decision as to what type of treatment he wants. Breast cancer, on the other hand, uses all three types of treatments. The surgeon will go in and remove the tumor. If the tumor is large enough or there are lymph nodes involved, then the medical oncologist will give chemotherapy to attempt to eradicate any disease that might be located elsewhere in the body, and then we come in and try to sterilize the tumor bed where the surgeon had done his treatment.
Those of us who have lived long enough to remember cancer treatment from decades past I can recall just members of my own family and friends that had radiation treatment, and it was somewhat hellish. But things have improved. Tell us how radiation oncology has improved over the years.
Radiation oncology has gone through a series of evolutions. Radiation was first discovered in 1898 and was used to treat cancer about a year later. The first series of cancers were treated with using radioactive radium needles that were then placed directly in the tumor. And yes, you could eradicate the tumor, but because the radium basically gave off its radiation over a large area, you would also cause a lot of damage in surrounding structures. So prostate cancer or rectal cancers, you could eradicate the tumor, but then you would destroy everything else in the area. Mm-hmm. Then it was discovered how to make man-made radiation, and we were able to then aim a beam of radiation at a particular area. The first beamlets that were made were very poorly penetrating, so they would cause a lot of skin damage as they were penetrating through in order to reach the tumor. Mm-hmm. We now have developed ability to treat with higher frequency radiation, which then penetrates further and allows for us to deposit more of the energy deeper into the surface where the tumor lies, and so we're able to avoid a lot of the skin damage. Another major advance that's been done is that the computing power has allowed us to be able to locate the areas we want to treat to a much better degree. When I started out, which wasn't that long ago, we actually had to take physical films and hand draw them onto the computer screen to show where we wanted to treat. We now can incorporate that data directly into the treatment planning. When I started at MD Anderson, we used to start running an iteration at 6 o'clock in the evening as we were getting ready to go home, and if you were lucky, when you came in the next morning, you would have a plan waiting for you. Now I can sit at the computer, I can outline all the structures on the computer screen, tell my staff what it is I want to do, and within a few minutes they can actually have a plan for me to look at. If I don't like it, or if I think some things need to be modified, we can tweak it. So we are able now to aim our beams of radiation more precisely and use radiation beamlets that are more attuned to the area we want to treat.
And thus you minimize damage to other non-affected tissue, and you...
Precisely, because radiation in and of itself does not discriminate between healthy tissue and normal tissue. It will kill anything that receives a high enough dose to cause the cell damage. Now there can be some cell repair, but if we get a high enough dose to any cell, we can kill it. So what we do is now we basically paint a dose cloud over the area we want to treat so that we bring in our beams from typically for many cancers 4, 5, 6, 7 different angles so that no one particular area is receiving a high dose except for where the tumor is located.
Well, that's amazing. What are the potential side effects from treating cancer with radiation?
It depends upon the area that we are treating. As I said, radiation, much like surgery, is a local, regional type of therapy. So if I'm treating someone's lung, they don't have to worry about losing the hair on the top of their head. If I am treating someone's intestine, they don't have to worry about developing a cough from their radiation. So it really depends upon where we're treating. If we're treating, say, the head and neck region, you're more likely to have things affected that are fast-growing tissues, salivary glands. So patients who are treated with both chemo and radiation typically have a decrease in salivary production after treatment of their cancer. They also, during the course of therapy, will develop like a sunburn inside their mouth, so they'll have difficulty swallowing. They also will develop that sunburn type appearance on their skin surface, so you can see that. If we're treating the lung, we cause local irritation in the lung, so it causes, or can cause, the patient to develop an esophagitis, an irritation of the esophagus, so that it's like getting a sunburn on the esophagus. They can develop a cough, shortness of breath, temperature, a pneumonitis from the therapy, all during the course of therapy or shortly thereafter. Usually it will clear up within 4 to 6 weeks after finishing the radiation therapy. If we treat other areas, again, there's local side effects that can occur. Treat the intestines, then you're more likely to see things of increased frequency of bowel movements, looseness of stools, diarrhea. Bladder, you can have increased frequency of urination, tingling or burning on urination. The main thing is with most patients who receive radiation therapy, they typically will not experience side effects for this first several weeks going into the treatment because the damage is building up. It will peak on or about the last day of treatment, and then the healing process kicks in, and usually most patients notice within 2 to 3 weeks after finishing their course that they're getting better, and most patients are back to their normal self within 4 to 6 weeks after finishing their course of radiation. Now, I caveat that with the word most because every individual is different and you never can guess how someone is going to respond. I've had patients who will come in and say, I'm not worried about the skin reaction. I go outside and I tan very easily. I've had other people come in who say, oh, I'm really scared about developing the skin reaction because I go out in the sun and I just burn. And I've seen patients who were worried about the skin reaction sail through without any problems, and patients who said it wasn't going to happen, see the problems happen. I have seen patients who I thought were going to develop side effects who didn't, and people who I thought were not going to develop side effects develop some strange ones.
And so after this exhaustive research, you've discovered that we're all different.
We are all different. There is no way that I can tell any one person what their particular side effect will be. What we do is we tell patients what the potential side effects are, what the probable side effects are, and then we address them if and when they do occur.
Very well. The UT Health Science Center has a new linear accelerator which delivers radiation treatment to patients. How is it different from what preceded it, most linear accelerators?
Well, as I kind of alluded to a few minutes ago, treatment with radiation and all types of treatment for cancer has been an evolution and a revolutionary approach. Varian, which is the company that made our linear accelerator, its #1 selling linear accelerator is called a Clinic. It's been in business and been in service for about 20 years. It is a standard workhorse linear accelerator. The next generation was called the Trilogy. It came out about 5-6 years ago, and it incorporated changes and new developments, so faster computing time. We were able to bring in more types of different treatments into the machine. We were able to do what's called image-guided radiation therapy. You could do what's called a cone beam CT, so you could see before you actually started doing the treatment what you were treating that particular day as opposed to what you saw just before you started treatment when you did your planning session. So you were able to make modifications on a daily basis with that system. The problem with that system was it was an add-on to the old system, so you ended up with a bank of computers and screens that would occupy a whole wall. The system we have now is called TrueBeam. It has one computer that runs the entire system, so you only have one computer interface. You have two screens, one so you can watch the patient, make sure that nothing is going wrong in the room, or if the patient's not having a problem, and one screen to actually show you what the machine is doing, as opposed to 6 or 7 in the generation just preceding this one. This machine also has incorporated new technology so that it's able to kind of rev up faster so that there's less of a lag time from the time you actually turn that button on to start the radiation and the time it reaches its maximum dose. It also is able to give a flatter beam so that the beam of radiation is more precise or more attuned to what you actually are planning to give as opposed to over an entire spectrum. It also has some other capacities that we're working on with Varian. As I said, the generation just before, you can do what's called a cone beam CT at the beginning of a treatment and see how the patient's anatomy has changed on that particular day. With this new machine, you'll be able to do a cone beam CT during the treatment. You can track the tumor as it's moving while the treatment is being given. And with the table that we're working with Varian to produce, the table will be able to move up and down, pitch and yaw, so we can aim the beam of radiation more precisely, have smaller margins, hopefully thereby giving a higher dose to the tumor so we can eradicate it while giving less dose to the surrounding tissues, causing fewer side effects.
And the tumor would be moving because the patient's breathing? Or
patient's breathing, the patient's just
can't
naturally
lie
move.
absolutely still.
No one can remove absolutely still.
Right. Okay. Well, that makes sense. Looking into the future, which looks like the future is kind of now, but looking into the future of radiation oncology, what do you see in the coming down the pike?
There are many advances taking place in the field of radiation oncology. Down at MD Anderson, they have a proton machine, which they hope will become the future for radiation therapy. My personal opinion is I don't think it will. It's just it's cost prohibitive. It costs $100,000 to deliver a portion of the treatment with that type of machine. And in this day where we're having problems finding the money to pay for health care, I don't see that being the way. What I see happening is more development along the lines of what we're doing here, where we are obtaining machines that are able to deliver the radiation more precisely, able to avoid treating the nearby normal tissues so that they have fewer side effects. Our computing power is allowing us to plan with a greater degree of accuracy. We can actually now do a CT on a patient and a part of the planning session where we do the CT over time, so we get what's called a 4D CT. We can map the tumor through breathing cycles so we can see how it's moving during the CT. We can then map that out, arrange for either treating at only a particular portion of the respiratory cycle, or we can treat differently according to where the patient is in the respiratory cycle or where the tumor might be during that respiratory cycle. So we're able to redefine the area we need to treat, and I think that's where we're headed. We're going to be able to define tumors more precisely, be able to treat quicker and more precisely while avoiding those normal tissues and decreasing our risk for side effects.
And I guess the bottom line is we would then hope for better outcomes.
It is basically been said, and probably is to most degree correct, that the higher dose we can deliver to the tumor, the more successful we are in eradicating the tumor. That might not be completely true, but one of the fields where radiation has advanced is doing what's called stereotactic radiosurgery or stereotactic body radiosurgery. And rather than trying to deliver a field of radiation to cause the cellular damage that I mentioned, is where most radiation therapy works, you deliver a very high dose over a short period of time to that tumor so that you can literally burn the tumor out.
Well, very well. Doctor, thanks very much for your time. Very interesting.
Well, thank you very much for having me.